All right, so here's our second video in the series. This one's over the hypovolemic type of shock by me, Nick Riesenberg. So physical examination and signs and symptoms. So there are three stages of hypovolemic shock, and it's all based on the amount of volume of fluid that is lost. So the first stage, which is mild, that's the earliest stage, and a person loses 20% or more of their blood volume. This stage can be difficult to diagnose because blood pressure and breathing will still be within normal limits, and symptoms at this stage are pale skin due to all the volume loss, and they may be experiencing anxiety as well. And then in the moderate stage, the person will lose 20% to 40% of their blood volume. The patient may experience increased heart rate and respiratory rate. Blood pressure may still even be within the normal range, but the diastolic pressure may be high. So the patient may begin to sweat and feel more anxious. Those two stages are a little bit harder to diagnose because of that blood pressure not reacting yet and not trying to counteract for the loss of the fluid volume. And then in severe stage, the person may lose 40% or more of their blood volume. At this point, the patient's systolic pressure will be 100 millimeters mercury or lower. So it will decrease the blood pressure. They may be tachypnic, tachycardic, and the previous symptoms will be present, but amplified along with a weak pulse. So they'll still be diaphoretic and seem very, very anxious. So as I was saying, this is a harder one to diagnose through these stages until the severe because their blood pressure isn't really reacting yet, and you're not being able to monitor that yet. So other physical signs and symptoms: weakness, lightheadedness, confusion, anxiety, pale skin, diaphoresis, all that because of that fluid loss. And that would be something you could do with your IPPA and just visual inspection of them. Possible chest, back, or abdominal pain. This could indicate a vascular disorder, something internal that has gone wrong, not an external injury that's causing blood loss. And then in the moderate or severe cases, the tachycardia, tachypnea, and the high blood pressure. So imaging, contrast enhanced multi-detector CT or CECT for the chest, abdomen, and pelvis is the first line of imaging, can be used to identify the type of shock. So that's just a imaging tool that they use to see like what is causing this form of shock in the body if it's an internal problem, not an external issue, as in trauma or gunshot wound, stab, or blunt trauma to the head or something like that. Echocardiogram, which is used to see how well the heart is filling with blood and squeezes the blood, how effective the heart is still pumping, what volume is left. Endoscopy, that is used to help find the bleeding source if it's in the GI or gastrointestinal tract. So if there's a GI suspected, endoscopy is used to determine the source of where that bleeding is located. And then a chest X-ray if there's a perforated ulcer, or Boerhaave syndrome is possible. I don't know if that's the exact pronunciation, but Boerhaave syndrome is spontaneous perforation of the esophagus. So that is also used in those terms. So with hemodynamic monitoring, you're going to use a Swan-Ganz catheter, as you always will, to exclude other causes of the shock or to monitor the hemodynamics. So the values you're going to monitor, all the values are going to be decreased because they have a lack of circulating volume. Except for the SVR, systemic vascular resistance, that's going to be increased because the lack of volume is going to make it harder for that volume to move through the systemically. So your CVP, your PAP, your PCWP, cardiac output, all that is going to be decreased because there's a lack of volume to be circulated in the first place. So pharmacologic options, you've got somatostatin and octreotide infusions to reduce gastrointestinal bleeding, and vasopressin for the same things. But it's associated with hypertension and arrhythmia, so it should be considered secondary to the more definitive measures, which would be those two previous medications. And those medications, they have similar effects as the vasopressin, but they do not cause coronary vasoconstriction. So that's a benefit of that one. And the octreotide is similar to the somatostatin, but it has a greater potency and a longer duration of action. So all of these are vasoconstriction drugs that will help increase the blood pressure, so more blood can be circulated to perfuse the tissues and organs. And then lactated ringers, so that is used to increase the vascular volume anything like a fluid bolus of some sort, that the lactated ringer is a diuretic, or so it's going to increase more fluid into the body, which is the bigger part of it. If you've got now you're vasoconstricting the vessels to help the blood, what little volume is there to move to the organs and the tissues. But now we need to increase that vascular volume so that we are being able to not only move it around effectively, but we have enough to go around effectively. And so blood gas anomalies in the early stages, you might see a respiratory alkalosis or a high pH from hypocarbia. If they're taking, if they've got anxiety and they're hyperventilating, it's going to cause the respiratory alkalosis. But then in the later stages, as you've lost some more volume, you're losing more nutrients out the body, you're going to see a metabolic acidosis because of all that nutrients leaving the body. So with mechanical ventilation for hypovolemic shock, I didn't see a whole lot of indications for specific ventilator modes. I did see high flow may not be considered mechanical ventilation, but it spoke highly of high flow, that because it gives that high flow, you can have a higher oxygen concentration there, and it doesn't give an excessive amount of PEEP. So that's kind of the bigger thing with the mechanical ventilation for this shock. You want to avoid excessive PEEP, but if you want to balance an abnormal blood gas, then volume control, assist control would be a good mode to use. You're going to go into the mechanical ventilations if they're in severe respiratory distress or going into failure. And then pressure control and assist control, that is to help keep that hemodynamic stability, because we don't want excessive intrathoracic pressures to press against the great vessels to impede upon the hemodynamics. So concerns when using the positive pressure ventilation, it's that hemodynamic concern that you already have a decreased output, cardiac output, and decreased venous return. So that is already being caused by this hypovolemia. With excessive positive pressure, you're going to also decrease cardiac return and decrease venous return because of that excessive intrathoracic pressure on the great vessels impeding output and return. So just pathophysiology of the hypovolemic shock. So hypovolemia will cause venous return, a decrease in venous return. So the decrease in venous return will decrease the preload, which in turn decreases the cardiac output, which will cause hypotension. And then that leads to perfusion failure and tissue hypoxia because you're not getting volume around. There's not enough volume to go around. So your tissues are the first thing that's going to be not perfused, because your body's going to want to protect the vital organs first. But as you continue to lose blood volume and it's not being distributed, you're going to have organ dysfunction, because not all the organs are vital. It's going to prioritize the brain, the heart, and the lungs. But other organs may start to deteriorate. But once that happens, then a lot of other organs are going to start to deteriorate. So you get into organ dysfunction and then multi-organ failure. So this, as you can see, is a dangerous process. It's a dangerous road to be on if you don't counteract this quickly with some more fluid, find the source of the bleeding or the volume loss, and address that. So in summary, signs and symptoms: if it's an external cause, if it's a trauma resulting in excessive blood loss, you need to find where that, it probably could be fairly obvious if they come from a car wreck. It might be multiple places: a gunshot wound, a stab wound, blunt force trauma to anywhere in the body, a head injury. You're going to locate that and address that. And then also the internal options as well. You're going to see if it's more on the internal, they don't have an obvious place of where blood is being lost or fluid. You're going to look for them to be pale, diaphoretic, anxious, and that's going to give an indicator that there's something going on in the body, that they are losing fluid and volume, and they may be confused as well. So imaging tools, the CT is the first kind of line of imaging that you want to use to identify the cause of shock. And if you suspect a GI bleed, then you're going to want to do an endoscopy to find that source of that bleeding. So with the hemodynamics, all the values are going to be decreased because of the loss of that intravascular volume. So your CVP, your PAP, your PCWP, your cardiac output is all going to be decreased. your SVR will be increased because of the lack of that volume circulating. And so pharmacologic, we went over those vasoconstricting drugs to help dilate or vasoconstrict those already dilated vessels. And then you want to implement its lactated ringers or some sort of fluid to increase that intravascular volume. So now that you've got a constricted vessel to help increase that pressure to move the volume around, but you want to increase the amount of volume in there because you already have lost a great deal, or at least a good deal of it. And then in mechanical ventilation, I saw that high flow was something that was utilized. That was a good option because it gives you that flow, that oxygenation without giving an excessive PEEP. But that's the main thing with this. You want to avoid that high intrathoracic pressure so you don't impede on the vessels, the great vessels that need to increase their cardiac output and increase the venous return when it's already been depleted and it's already decreased. So increasing that to any point would just also impede on that venous return and the cardiac output. So this was hypovolemic shock, and thank you very much.